Hello and welcome everyone. Today we'll be discussing about hypophosphatemia in critical illness. This is a comprehensive review how to use it and manage it in the ICU. So what exactly is phosphate? It is an anion which is present intracellularly and it is critical for our cellular function. You must have heard of ATP, GTP. The P is the phosphate. So that is basically the energy currency of our body. It is constituent of the nucleic acid, structural proteins, phospholipids, everything. So how it is distributed in the body? 85% is stored in the bones and teeth, 14% in the cell membranes and the intracellular fluid, while only 1% is present extracellularly. So in the blood we have a very low concentration, 0.8 to 1.5 millimoles per liter. While its concentration intracellular is very high, 100 to 110 millimoles per liter, and the total body's 1% is phosphate. So it is essentially under a hormone control which is predominantly because of calcium's metabolism. So the key hormones are the PTH, that is the parathyroid hormone, which mobilizes the phosphate stores, increases the serum phosphate through osteolysis, and vitamin D3. Vitamin D3 which increases the GI absorption and renal reabsorption of phosphate. You have calcitonin which increases the renal excretion and stimulates the bone formation, reducing the serum phosphate levels. And finally, you have the FGF23 which reduces the GI absorption, increases the renal excretion and is suppressed by the PTH release. So how does critical illness disrupt this phosphate balance? So there are multiple factors which can cause disruption in the phosphate metabolism. These are reduced intake in critical illness, impaired absorption through the GI tract, increased excretion via diuretics or the renal replacement therapy, or the transcellular shift. Special conditions can cause the phosphate change like free feeding syndrome, which can decrease because once the insulin level increases, it can cause a precipitous drop in the high phosphate levels. Next, sepsis, certain gram-negative infections, Legionella can cause hypophosphatemia directly, and the exact mechanism is uncertain. Tissue injury, that is burns, muscle damage like rhabdomyolysis, tumor lysis, all these can release the phosphate from the intracellular space, causing hyperphosphatemia. So how common is hypophosphatemia in our setup? As it is a very varied population, it can range from 10 to 45%, 75% in the overall incidence, because the definition was very different and the population is also very different. The next, you have the large studies like the 70,000 patients which used a cutoff of 0.8, where we found that the hypophosphatemia was in 34% of the cases. However, severe was quite less, around 1% cases had severe hypophosphatemia. So how do we define this? There is no really scientific or universally agreed upon threshold. A meta-analysis revealed that a threshold ranging from 0.48 to 0.94 across 12 studies, nearly a twofold variation was seen. And so for this particular review, we are taking severe as 0.3, which means you have to treat immediately. Moderate and mild, we exactly don't know how to deal with them. Normal, as we have discussed, is 0.2 to 1.5. So what are the complications of severe hypophosphatemia? You can have muscle weakness, which is the predominantly and the most important thing. The next is cardiac issues. You can have neurological problems like neuropathy, delirium, seizures, coma, hematological, and rhabdomyolysis. The exact threshold below which these problems occur is not really known, but definitely if the levels are less than 0.3 millimoles per liter, do treat it. The associated outcomes is there is a lot of conflicting evidence regarding the increased mortality, and some have shown that there is increased and some have shown no increase in mortality. Whether it is an independent predictor or not remains a question. So the question remains whether it is the cause of the severe illness or it is a consequence of the severe illness. So this is the gap that we are having. We don't have really any evidence to show that what exactly is the effect of hypophosphatemia and whether we should treat it or not to treat it. Regarding phosphate-free replacement options, you have oral nutritional intake. You can take it through your diet. artificial nutrition, or you can give it enterally through tablets like sodium phosphate tablets with 70% bioavailability, and intravenous, that is direct IV administration. Enteral tablet, as that is the sodium phosphate, is can be given even crushed by nasogastric tube. The side effects are nausea, vomiting, diarrhea. However, it is quite safe, effective, and pretty inexpensive. The intravenous form has two parts. It can be either sodium or potassium. If you are giving the potassium, which is the more frequently available, you should be very careful because potassium level or the potassium range in the blood serum is very low. So you have to keep in mind how much potassium you are also giving. So because a lot of boluses were being given, you don't really find potassium phosphates readily available in the ICU pharmacies. Regarding the role of enteral versus intravenous, there was a observation study, especially when there was a IV phosphate deficiency in the US. They found that the outcomes were essentially similar. RCT was done and it found that it is quite non-inferior to intravenous phosphate. However, you must keep in mind that this was in moderate to mild patients and not for severe cases. Regarding the correct practice, there is a lot of variation. Almost 23 to 56 ICUs did not have any specific recommendation. The treatment variability was as high as 80%. However, in severe cases, almost all severe cases were treated, that is less than 0.3. So this variability that you're seeing means that whether they were treated or not and what was used for treatment. So this was based on a Queensland study of 12 ICUs. So the current recommendation is, if it is severe, do treat it IV. If for moderate and mild, there is a controversy. Moderate you can give enteral, and in mild at all, if we should bother or not, we are not very sure. However, all this recommendation that you are seeing in this screen right now is not based on evidence. This is essentially based on expert opinion and some retrospective studies. So there are major research gaps. That is, whether we should daily monitor it or not. What is actually the definition of hypophosphatemia? How should we replace it, and what is the optimal treatment? Everything is not answered. So there are some lessons we have learned from previous interventions, like the tight glucose control, the early goal-directed therapy. It doesn't mean that these things are bad. It just means that we don't know yet what are our thresholds, how to monitor it, how to manage it, and what are our endpoints. Until and unless we know all these things, exactly knowing what we need to do and when, especially in a volatile situation and of a marker which is continuously varying over time, becomes very difficult. So we have a lot of studies going on. There is a UK observational study which is looking into the institutional practice. There is the Australian cluster crossover RCT which is looking at the various thresholds of treatment, and you have a Iranian trial which is looking at enteral versus IV. So we might be getting a lot of information in the near future. Regarding the research priorities, we need to define our thresholds, establish the causality, whether it is the cause of the severe illness or it is the effect of the severe illness. Determine the treatment necessary, the management, optimum management plan, and finally we need our cities which are large enough to generalize our findings. So what we need are more observational study looking into the incidence aspects and more clinical trials looking at the management aspects. So for practical recommendations, in severe cases, do treat it, prefer the enteral route in the other cases. IV always use with caution, especially if you are using the potassium one, and address the underlying cause. It's not that just replacing potassium is enough, you have to treat the underlying cause, especially things like the refeeding syndrome, insulin infusion, diuretics. You can't ignore them. So the key takeaway is that it's a common condition, but what exactly is the significance, we are not very sure. There is conflicting evidence on its effect on being an independent predictor of mortality. There is no trial evidence whether it should be given to mild and moderate cases. There is a lot of variability in our practice and further research is needed. So the path forward is to treat severe cases, look into the research into the impact of the mild and moderate hypophosphatemia on critical illness, and target the research agenda so that we have